Today we are going to delve into the world of nephrology. Our topic of discussion are urinary abnormalities. And since this topic encompasses a lot of pathologies, we have divided this lecture into two parts. The first part of this lecture, which we are going to discuss today, is concerning mostly to the azotemia or the acute kidney injury, whereas in the next part of this lecture, we are going to discuss various terms like hematuria, polyuria, or proteinuria, etc. So let's get into the details. All right. To start off, let's revise some basic anatomy and physiology. This is the nephron, the structural unit of the kidney. And as you all know, there are various parts of the nephron, starting here from the glomerulus. The glomerulus is covered by a glomerular capsule, and then it leads to a proximal convoluted tubule. The proximal convoluted tubule then leads to a loop of Henle, or it's called the loop of nephron. It has a thin descending part and a thick ascending part. This loop of Henle leads to the distal convoluted tubule, and afterwards, from the distal convoluted tubule, we can go forwards to the cortical collecting duct. And after the urine, after getting filtered here from the glomerulus, passes through all these parts of the nephron and then goes to the renal papillae. And various renal papillae combine at the renal pelvis, and the urine eventually drains into the ureter. This is the blood supply of the kidney. Interlobular artery, it branches and gives rise to the afferent arterioles. You know, the afferent arteriole means the arteriole or the blood going towards the kidney. The afferent arteriole branches into the various glomerular tufts in the glomerular capillaries, and afterwards, here it forms the efferent arteriole. So efferent means going away. So the efferent arteriole carries the blood away from the glomerulus, and afterwards, from the efferent arterioles, the peritubular capillary network is derived, and this peritubular capillary network eventually drains into this interlobular vein. Now, one thing is important as regards to the kidney, that the kidney has no collateral blood supply. Every artery supplying the blood to the kidney, or the part of the kidney, is an end artery. There is a network of arteries called the arcuate arteries, but there is no collateral circulation like in the intestine, or for example like in the brain. So if there is a ischemia of one artery or one part of the blood supply, generally that part becomes ischemic or necrotic. So the kidney is very sensitive to hypoxia or decrease in the oxygen supply, and that's why whenever there is an acute hypovolemia or hypoxic episode, the kidneys are generally affected, and that is majorly a topic of discussion concerning the acute kidney injury. All right, this is the general outlook of how does a nephron look. This is just to revise the basic concepts, and now just let's go on to our main topic of discussion today. Our main topic is azotemia. Azotemia, or it is also called as acute kidney injury. Let me first define what is azotemia. Azotemia is generally defined as the acute kidney injury occurring over a period of hours. So it is a very acute process. Injury occurring over a period of hours, which leads to the decrease in the GFR, or the glomerular filtration rate, leading to the rise in the blood urea nitrogen and creatinine. So it is an acute process which causes some damage to the kidney, and the result of that damage is a decrease in the GFR, or the glomerular filtration. As the glomerular filtration decreases, the waste and the toxins start to build up in the blood, and this leads to the increase in the BUN, or the blood urea nitrogen, and the creatinine. So as you know, BUN, or the urea, it is produced in the liver, and it is a byproduct of protein metabolism and the various degradation of proteins in our body, and it is generally secreted through the kidney, and the secretion of the urea is flow dependent, which means that when urea is filtered and goes into the tubules, if there is increased flow of the urine, then whole of the urea gets filtered away or excreted. But if the flow of the urine is less because of any reason, then the urea has more time in contact with the tubular cells, and then there is some absorption of the urea. So in high flow states, the body flushes off the urea very quickly, and in some low flow states, or the low volume states, the urea can get absorbed. As far as creatinine is concerned, creatinine is a byproduct of the muscle creatine byproduct, and it is a very good tool to judge the GFR, or the glomerular filtration rate. The reason being that creatinine is produced in a body, and then when it is filtered, the whole of it is excreted. No part of it is absorbed. Just a minor bit of it is secreted by the kidneys as well, which can overestimate GFR slightly, but that is very negligible for practical purposes. So creatinine, or more specifically, the creatinine clearance, is a very good marker or indication of GFR. Whenever we have some time, for example, in patients with a chronic renal injury, we use the creatinine clearance as a marker of GFR. But in some acute conditions, because creatinine clearance requires the urinary volume for about 24 hours and the measurement of the urinary concentration of the creatinine and the plasma concentration. So we need minimum 24 hours for the urine sample to be collected, and then we can have a good estimate of the creatinine clearance. But in some acute process, for example, in acute kidney injury, as we are going to see, we don't have that much time to wait for the urine sample collection. And in those circumstances, the plasma creatinine level can be a good indicator of the urinary function, or the GFR. If a patient has acutely increased plasma creatinine concentration, that then generally means that his GFR is going down, because both of them are in inverse relation when it comes to the creatinine clearance calculation. As you know, creatinine clearance is calculated by the U multiplied by V, which is U means stands for the urinary concentration of creatinine, and V stands for the volume of the urine in the 24 hours, and that is divided by the plasma creatinine concentration. So the plasma creatinine is in inverse relationship with the creatinine clearance, and creatinine clearance, as you know, signifies GFR. So if we make a correlation, we can safely say that plasma creatinine is an inverse relationship with the glomerular filtration rate. As the plasma creatinine starts increasing, the GFR starts going down, and vice versa. So these are the basic tidbits which you have to remember when it comes to the BUN and the creatinine. So you can safely define azotemia as any condition that leads to an increase in the BUN and creatinine over a period of hours or acutely. Having said all that, let's look at the various types. What can be the conditions that can affect the kidney so acutely that the kidney's GFR starts going down and the waste product starts accumulating in the blood? So if you look at the anatomy of the kidney, the blood supply, there is the venous outflow, and this is the arterial inflow. So for a purpose of understanding and making it simple, we have divided the azotemia into three types. The number one is prerenal. Prerenal is anything before the kidneys. It involves the kidney's arterial blood supply. So anything which decreases the blood flow inside the kidney is termed prerenal azotemia. We are going to see different conditions in the coming slides which cause prerenal azotemia. Now, after prerenal azotemia, simple one is anything which obstructs the outflow tract, the ureter. For example, BPH or prostate pathology in the males and cervical cancer in the females. Anything which can obstruct the ureter, and for it to be clinically significant, the obstruction has to be bilateral. Because as you know that if one kidney is obstructed, then the other kidney can compensate for that, and a person can survive on one kidney. But for clinical azotemia, the obstruction has to be distal, and distal means that either at the level of the bladder or the urethra or a big mass which can involve both the ureters. So whenever there is bilateral obstruction, then that can lead to the post-renal azotemia. We have done the pre-renal before the kidney, post-renal is after the kidney. Now let's look at the third part, which involves the kidney itself. So any pathology involving the kidneys, whether it involves the cortex or the medulla, that is classified into the renal azotemia. So this makes it very simple to understand. Pre-renal means anything before the kidney or the blood supply occlusion. Post-renal is anything after the kidney, and renal means anything which involves the kidney itself. Let's look at a few conditions that can cause this acute kidney injury or azotemia. Now, to start off, let's look at a few pre-renal conditions. So you can before going into the discussion, you can safely say that kidneys receive a lot of blood supply from the heart, and they have a lot of because they are a small mass and the blood supply is so large. So anything that is any hypovolemia or anything that can lead to the decrease in the blood supply of the kidney can lead to the acute kidney injury, if especially if that blood supply loss or hypovolemia is so large and so acutely that the kidney is unable to compensate for it acutely. So any kind of hypovolemia, what kind of hypovolemia it is? It can be a hemorrhage or a diarrhea or dehydration occurring acutely. This can lead to the prerenal failure or acute prerenal azotemia. If there is a decrease in cardiac output, for example, in patients with myocardial infarction, or in patients with congestive heart failure, the decreased cardiac output leads to the decreased blood supply in the afferent arteriole. The kidney does compensate by increasing the renin secretion from the juxtaglomerular apparatus and increasing the angiotensin II concentration, which constricts the efferent arteriole and tries to maintain the GFR. But if this process is occurring continuously and it is occurring very acutely, then the kidney might not have that much time to compensate for that. And then and if that overwhelms the compensatory process, then this prerenal azotemia can occur. Similarly, decreased effective circulating volume. As we discussed earlier in our lectures concerning the edema, that effective circulating volume basically is comprised of two parts. Number one is the plasma blood flow or the hydrostatic pressure and the oncotic pressure. So anything that decreases the plasma hydrostatic pressure, for example, the above two conditions as we just talked about, the hypovolemia or the decreased cardiac output, that decreases the effective circulating volume. Or if there is protein loss or the liver is not making enough proteins, for example, in cirrhosis patients, then that can lead to the decrease in oncotic pressure in the vessels. And with that decreased oncotic pressure, the effective circulating volume goes down, because when the proteins are lost or the proteins are not being made, there is not enough oncotic pressure to keep the blood in the vessels, and there is third space fluid loss. It can be in the form of cirrhosis, ascites in cirrhosis patient, or in patients with nephrotic syndrome, for example, who lose a lot of proteins in the urine. It can be in the form of edema, like pulmonary edema or generalized body edema. So the blood is basically lost, or the fluid is basically lost in the third space, like in the peritoneum or the pericardial cavity or the pleural cavity, and it does not contribute to the circulating volume. And lastly, if there is some impaired renal autoregulation because of any pathology, but this is fairly rare, but the important ones here to remember are the hypovolemia, cardiac output decrease, or the effective circulating volume. Just remember that anything that decreases the blood supply of the kidney can lead to prerenal azotemia. And as I just talked about concerning the effective circulating volume, the congestive heart failure and the liver failure because of the loss of protein, albumin, which causes the oncotic pressure, and the congestive heart failure because the heart is unable to pump the blood into the kidneys adequately. These are the major pathologies concerning the prerenal azotemia. As a matter of fact, congestive heart failure is the most common cause of prerenal azotemia, generally in the hospitalized patients. All right, let's look at what can go wrong with the kidney itself. As you know, the kidneys are made up of basically 2 to 3 parts, you can say. The number one are the momus capsule, and then it contains glomerulus in it. The momus capsule leads to the tubules. So if there is any problem with the tubules or the interstitium which is present alongside the tubules, like acute tubular necrosis, as we are going to discuss further, that can damage the kidney and cause renal failure. If there is some damage to the blood supply within the kidneys, then that can, for example, acute ischemia occurring over in one of the lobar arteries, that can cause renal azotemia. Or if there is some damage to the glomerulus, for example, the glomerulonephritis, acute glomerulonephritis, or rapidly progressive glomerulonephritis. These are conditions which occur very quickly over a period of hours, and we have to act very promptly, otherwise the patient might die, and these are life-threatening conditions. So the important ones to remember as in regards to the renal pathologies concerning the acute kidney injury are the acute tubular necrosis, tubulointerstitial nephritis. These involve the tubules and the interstitium, and the acute glomerular nephritis. The most common one is acute tubular necrosis. Just what we talked about here. Vasculitis, I just want to mention the vascular, in the vascular part of the renal injury. Vasculitis is a rare complication, but this is something that can affect the kidney if, either on its own or in combination with some syndrome or some disease. For example, in thrombotic thrombocytopenia, hemolytic uremia syndrome, TTP-HUS, as you know, this can involve the kidneys and it can cause vasculitis and renal damage. And if there is malignant hypertension means that blood pressure greater than 200 systolic and greater than 120 or 130 diastolic. And this occurring very acutely can damage the kidney, can cause vascular necrosis. And this is a very serious condition and we have to manage it very promptly. Otherwise, this can lead to very fatal sequelae. Now let's just talk about a few. This is the nephrotoxins are the ones that concern the acute tubular necrosis. It can either be nephrotoxic or it can be because of any sepsis or infection or ischemic. We are going to discuss ATN in slight detail in the coming slides, but I just wanted to mention that the number one cause of acute tubular necrosis occurring in the patients, it occurs mostly in the hospitalized world or the patients admitted in for CHF, for example. And ischemia is the number one cause. There is a very thin line of demarcation between the prerenal azotemia and the renal azotemia occurring because of acute tubular necrosis. This will be explained in detail when we go to the approach to the patient, but I just wanted to give you an idea. Whenever there is prerenal azotemia, for example, in a patient with heart failure, there is decreased blood supply to the kidney, and the patient is generally in prerenal azotemia. But that azotemia is generally reversible. That means that if we manage the heart failure or if we manage the hypovolemia, then the patient starts getting better. But if it keeps on going for a long period of time and either the patient is not in the hospital or if there is not enough adequate management of that condition, that eventually that can lead to the ischemia of the tubules or the necrosis of the tubules. And that will manifest in the form of acute tubular necrosis. In this acute tubular necrosis, you will see when we discuss the urinalysis that the tubules fall off into the tubular cavity, and they can either obstruct the whole tubular tract, or either they can be excreted in the urine in the form of renal tubular cell casts or the muddy brown cast. So that ischemia or necrosis, once it happens, it generally becomes irreversible if it is very much prolonged. If we act quickly in the earlier phases, if we pick it up early and the patient can present early, then that can become reversible. But afterwards, it also has three phases. That initially presents as oliguria or anuria, which means oliguria means decreased urine output. For example, less than 400 mLs per day. A general urine output is about 1 to 2 liters per day. But if a patient has had less than 400 ml of urine production in one day, then that can be regarded as oliguria. And that can be a presentation of acute tubular necrosis. Or the patient might have not produced a urine in 24-hour period and no urine production. That becomes very serious. That can lead to something which we call clinically as renal shutdown or the renal necrosis. And that presents generally as acute tubular necrosis. So prerenal azotemia can get converted into the acute tubular necrosis if the ischemia is long lasting and it damages the kidney's tubules. So this is to understand the concept of development of ATN. And there are certain markers, the urinalysis markers, which we are going to study further, which help us in identifying the prerenal azotemia from the acute tubular necrosis. Similarly, if there are certain drugs that damage the nephrons, for example, the most common ones are the aminoglycosides like gentamicin, or the loop diuretics like furosemide if used for a long period of time, or if there is some like the sulfur drugs, they can cause some toxicity, or if some penicillins, there are certain cross-reactivity with the penicillins as well. The major ones to remember here are the aminoglycosides or the gentamicin. They can be nephrotoxic to the renal tubules. Especially in older patients, it is imperative or very important to adjust the dose of those aminoglycosides if you are giving them aminoglycosides for any infection, or if you are giving them low diuretics, for example, to so that they can pee off the excess volume. It is very important to adjust the dose of the drug according to the patient's GFR or the patient's kidney status. GFR generally goes down with the age. And for example, after generally it is said it is a rough estimate, but you can have a good understanding by this that after the age of 50, every year there is 1 milliliter per minute decrease in the GFR. So a normal GFR of a person is around 100 mLs per minute. So with passing age, someone who is 60, his GFR generally can be around 70 or 80. So it is imperative that we keep in context the GFR of the patient or the renal status of the patient when we are giving them certain drugs which are nephrotoxic. Similarly, NSAIDs are also nephrotoxic if taken for a long period of time, especially in patients who are dependent on the afferent arteriolar blood supply. For example, in someone who has heart failure or someone who has hypovolemia, there is compensatory increase in the renin-angiotensin symptom. The renin-angiotensin symptom works that the angiotensin 2 constricts the efferent arteriole, and the prostaglandins are the vasodilatory substances of the kidney. They vasodilate the efferent arteriole and they combine to maintain the GFR. Now, if you have given an NSAID to the patient and the NSAIDs inhibit prostaglandin production, that can lead to a decrease in the efferent arteriolar dilatation. It can constrict the efferent arteriole, and that can acutely cause renal failure. So, non-steroidal anti-inflammatory drugs are the ones, especially in the context of someone who already has hypovolemia or prerenal symptoms of prerenal azotemia. They are very important as well to remember. All right, now let's go on to the post-renal. Post-renal is simple, as you know. If there is bladder outlet obstruction, in males it can be because of BPH or benign prostatic hyperplasia, or if there is some cervical cancer that can obstruct the bladder in females. So that can lead to bilateral obstruction of the kidneys. And whenever there is bilateral obstruction, the symptoms of post-renal azotemia will become evident. Similarly, if there is bilateral pelvo-ureteral obstruction, any mass in the pelvis that can obstruct the ureter, that can also lead to the post-renal azotemia. All right. Now, to clinically identify the cause of the azotemia in patients, we have some good markers like the BUN and creatinine. As I told you in the start of the lecture, azotemia is generally defined in terms of increased BUN or increased creatinine. So in a normal glomerulus, the normal value of the BUN or the blood urea nitrogen ranges from about 15 to 20. So you can roughly say that it is about 15 to 20. As far as creatinine goes, the normal value is about 0.6 to 1.2. So if we take out the ratio of BUN, blood urea nitrogen, divided by creatinine, it generally comes out to be around 15. For the marker of simplicity, we would use 15 as that calculator. So in a normal person with a normal glomerulus, this is an afferent arteriole. This circle here signifies kidney, or you can say glomerulus. And this is the efferent arteriole leading into the peritubular capillary network. Here we have a tubule. So in a normal person, the BUN and creatinine ratio is generally 15. So when the blood passes through the glomerulus and the filtration is done, in the efferent arteriole, the concentration remains the same because both of these substances are freely filtered through the glomerulus. And as far as the glomerulus is concerned, this blue here signifies the urea or the BUN, and this red here signifies the creatinine. So as I told you that the urea, whenever it is filtered, it is flow dependent. So if it is in a normal flow state, in a normal person, some of the urea will be absorbed because of the normal speed of the urine flow in the tubules. If there is some increased flow, any condition that can lead to an increased flow or flushing of the kidneys, like in hypervolemic state, for example, if a lady is pregnant, there is an increased blood flow or generalized increased vasodilation or increased urinary flow, or someone with syndrome of inappropriate ADH, SI-ADH. In such patients, when there is hypervolemia, the urea will get flushed off and there is decreased absorption. So in a normal person, there is some absorption of urea because of normal flow rates. But if you look at this red arrow or creatinine, this red arrow goes all the way, all the creatinine that is filtered by the glomerulus goes away into the tubules and is excreted. There is no net absorption. So when the urea is absorbed here, you can say that the BU and creatinine ratio generally remains the same as about the 15 in the efferent arteriole, in the efferent arteriole, and also in the peritubular capillary network. So this is when it is concerning a normal person with a normal glomerulus. Let's look at this detail in the context of the azotemia or the pathologies. If someone has prerenal azotemia, for example, someone with heart failure or hypovolemia or dehydration, then in the efferent arteriole, because both of these substances are decreasing in equal concentration, the creatinine this ratio remains 15. But because of hypovolemia, there will be slow decreased GFR, and decreased GFR will lead to the decreased flow rate in the tubules. Because of the decrease in the tubular flow rate, there is increased reabsorption of urea. This increased reabsorption of urea will lead to an increase in the BUN and creatinine ratio greater than 15. The creatinine is not affected because it is freely filtered and then excreted, but urea, because of the decreased flow rate, which is in turn because of the decreased GFR, because of decreasing in the prerenal volume, that can lead to eventually increase in the BUN and creatinine ratio greater than 15. So in the prerenal azotemia, the BUN creatinine ratio increases greater than 15 generally. Now, if we apply the same concept to renal azotemia, one thing important in renal azotemia is that because the kidneys are not functioning well, the urea gets accumulated into the blood, and whenever there is excess accumulation of urea in the blood, some of which is secreted in the form of in sweat from the skin, or some of which is lost by the GI tract. So eventually, whenever there is some renal azotemia, there is already some decrease in the urea concentration in the body. So the BUN and creatinine ratio is generally less than 15 already in the efferent arteriole, and the kidneys, the glomerulus freely filters urea and nitrogen and urea and creatinine, and the kidneys are not working well, so there is decreased absorption of urea here in the body, in the renal proximal tubule or the tubular cavity, and then that can eventually lead to a further decrease in the BUN and creatinine ratio. So comparing with the prerenal azotemia, in which there is increased BUN and creatinine ratio greater than 15, in the renal azotemia, the BUN and creatinine ratio goes down less than 15. So this is an important demarcation which helps us in evaluating that whether the renal pathology is prerenal or it is concerning the kidney. And now if we look at the third part, the post-renal azotemia, what happens is if there is some bilateral obstruction, it increases the backflow of urine into the tubular cavity. The urine cannot go out. And because of this backflow of the urine, the GFR decreases, and this leads to, again, the increased reabsorption of urea because of increased contact of urea with the tubular cells, and eventually the BUN creatinine ratio can increase to greater than 15. Over a long period of time, if this obstructive pathology goes on, then that can eventually damage the tubule because of hyperfiltration or the tubular damage. And eventually, in the latter part, when the kidney or the renal azotemia develops, the BUN creatinine ratio can go down less than 15. But for general purposes, you can remember that in prerenal azotemia and in post-renal azotemia, the BUN and creatinine ratio increases greater than 15. And in renal azotemia, the BUN and creatinine ratio goes less than 15. It generally decreases. All right. This was all the basic concept or the basic context of what we were going to talk about. Now let's look at how we are going to approach a patient presenting with azotemia. If someone comes to you in the hospital with azotemia or increased BUN and creatinine ratio, how you are going to approach that patient. All right. The number one thing to do, which will help us in identifying, as you know that if someone who has chronic kidney injury, for example, if someone has diabetic neuropathy, then that patient has some chronic injury going on and it is getting managed. But there can be a superimposed acute problem in that patient as well. So how do you diagnose that whether this presentation is either a new process or an acute kidney injury or a chronic renal failure occurring in that patient? For that, our best friend is the renal ultrasound. The number one thing you have to do is the renal ultrasound. This renal ultrasound will help you with 2 or 3 things. Number one, it will rule out any obstruction, because if there is any obstruction to the urine flow rate, the kidneys will be dilated or the ureter will be dilated or there will be hydronephrosis. So number one, it will rule out the post-renal azotemia or the post-renal cause of kidney failure. If there is hydronephrosis, then you are done. You know that there is some post-renal pathology going on and this is post-renal azotemia. Or if the kidneys are normal sized and there is absence of hydronephrosis, then you can effectively rule out the post-renal azotemia. The second thing it will do is it will help you identifying whether the pathology is chronic or the pathology is acute, as we are going to see. So the patient presented to you in the ER with azotemia with increased BUN and creatinine. What you have done is, number one, you have done a renal ultrasound. And in the renal ultrasound, as this is after the renal ultrasound, you have done a CT scan. And in the CT scan, what you see here are the large kidneys. This is the right side kidney, as you can see, is so much enlarged. There is a big mass. Compare the two kidneys here. This is a small, general, normal size kidney, and this is the kidney of the right side. So you know there is something which is enlarging the kidneys. This can be any obstruction. So this generally means obstruction, which generally means post-renal azotemia. So if you find out this, then you are done. Your the patient has post-renal azotemia and you have to investigate on those lines. But if you analyze and there is absence of hydronephrosis, then you do an ultrasound and analyze the renal parenchyma size. On the renal parenchyma, what you find out is that the patient has small bilateral kidneys. There is thinning of the cortex. There is some bland sediment and there is isosthenuria. That on the urine sample, after doing the ultrasound, you also perform urinalysis. On the urine sample, you find out that the urine osmolarity is the same as the plasma osmolarity. The kidneys are unable to concentrate or dilute the urine, and there is less than 3.5 grams protein plus over the period of 24 hours. All these features are the classical presentation of someone presenting with chronic renal failure. So you know that this patient who has all these features evident on ultrasound and on the urine analysis, this patient has chronic renal failure and it is not some acute process going on. So in this chronic renal failure, what do you do to manage the patient? There is symptomatic treatment, whatever the pathology, whatever the complaint the patient presented with in the ER. And you do your best to delay the progression of this chronic renal failure with the help of certain drugs, like if someone has diabetic neuropathy and that is presenting at CRF, then you can give him ACE inhibitors or ARB, angiotensin receptor blockers. If it is end stage and you find out that the glomerular filtration is very low, less than 10 ml per minute, then that end stage renal failure the patient will have to go on dialysis, unfortunately. And even if the dialysis doesn't help, then the final result we can do is to transplant the kidney. So this renal ultrasound can help us identify acute process occurring in a patient who has perfectly fine kidneys otherwise, or if there's the patient who has presented with signs and symptoms of renal failure, this is because of underlying pathology, some chronic renal failure. Now, if you have done an ultrasound and you find out that the patient has normal sized kidneys and there is intact parenchyma, then this is an acute renal failure. And this is, or in other words, acute kidney injury or azotemia. What is the next step to do in a patient with acute kidney injury? How do you differentiate whether this acute presentation is pre-renal or it is because of ATN or acute tubular necrosis? Here, you are going to look at the urine analysis. The urine analysis will help you a lot. Along with the ultrasound has done this part, has taken you to this point. Ultrasound has differentiated acute renal failure from the chronic renal failure. Now, to further differentiate acute renal failure, you do the urine analysis. If the patient has normal urine analysis, but there is oliguria, that there is decreased urine output in a period of 24 hours, and you do the urine electrolytes, and in the urine electrolytes, you find certain classical presentations. Let me explain these terms to you first before going further so that you can have clarity of the concept. There are two terms we are going to discuss. The number one is called clinically as FeNA, F-E-N-A, as you can see here. This FeNA stands for the fractional excretion of sodium. It is defined as the amount of sodium excreted by the body and divided by the amount of sodium that is filtered by the kidneys. So the fraction of the filtered sodium that is excreted by the kidneys, that is defined as FeNA. And as you know that there is a lot of sodium absorption occurring at the proximal convoluted tubules. The kidney almost absorbs 70 to 80%, you can say, the sodium that is filtered. So whenever the kidney tubules are working fine, the fractional excretion of sodium will be less than 1. So if someone who presents with the urine electrolytes or the urinalysis picture of FeNA less than 1, that means that the kidneys are working fine, the tubules are intact, and they are doing their job. Similarly, if the kidneys are able to concentrate the urine, and if the kidney tubules are working fine, then the urine osmolarity is generally greater than the 500 milliosmol liters per liter. So as you see here, that FeNA is less than 1%, and if the urine osmolarity is greater than 500 milliosmoles per liter. So you can clearly see that in this patient, although this patient has oliguria or the decreased urine output, the kidneys are working fine. These can be a markers of the kidney functions or the kidney tubular function. The kidneys are doing their job well, the tubules are fine, they are absorbing the sodium and they are concentrating the urine. So the kidney pathology is ruled out with the help of this picture. And all that can go wrong and cause this acute renal failure is something prerenal. And this can be defined as the prerenal azotemia. So let's just revise it once again for the matter of understanding. You have a patient with azotemia. What you have to do to rule out or to classify that patient as either prerenal, renal, or post-renal. You do a renal ultrasound or if needed a CT scan, and along with that you need to do a urine analysis. If a renal ultrasound you found the kidneys are slightly dilated, then you can proceed and do a CT scan, as you can see. And if you see that there is enlargement of the kidney on the CT scan, that can be hydronephrosis. And if the picture fits completely with the hydronephrosis, you can there and then define the patient as a case of hydronephrosis or the post-renal azotemia. If the kidneys are fine and the renal, then you analyze the renal parenchyma analysis. I'm repeating it because you have to understand it completely to go further. You found out that the kidneys are small or the cortex is thin, and there is on urine analysis there is isothinuria or decrease or the concentration of the urine is the same as the plasma, which means that the kidneys are unable to concentrate or dilute the urine. You classify that patient as chronic renal failure, and then whatever the symptom that patient is presenting with, do that management. On the renal parenchyma analysis, you found the parenchyma intact and the kidneys are normal. You can classify that patient as acute renal failure. The ultrasound has helped you up to this part. Now, to further evaluate this patient, whether he has prerenal failure or whether he has renal failure or acute tubular necrosis, you will do a urine analysis. You did a urine analysis. On the urine analysis was perfectly normal, but there was oliguria, that decreased urinary output, less than 400 mL over a period of 24 hours. You did the urine electrolytes and you found out this picture. The FeNA is less than 1, your urine osmolality is greater than 500 milliosmoles per liter. So you define that patient as a case of prerenal azotemia. This is because of volume contraction or hypovolemia, because of any cause, like the patient might have been bleeding, there might be GI bleeding, there might be the patient might have diarrhea, the patient might have hyperthermia, and he might have sweated a lot, or he might not have been drinking a lot of water in the last couple of days, or the patient might have some cardiac failure, congestive cardiac failure. There might be some vasodilation. This can be because of some sepsis or because of some drugs he's taking. There can be some renal vasoconstriction because of acute hypovolemia. This can be a compensatory mechanism, or this can be because of some drugs the patient is taking, or this can be because of some vasculitis that is affecting the prerenal vessels. And finally, the autoregulation might be impaired because of any mechanism. Now, you have reached this part, and you have diagnosed the prerenal azotemia. This picture is of prerenal azotemia. But you did an ultrasound and finally arrived at a diagnosis of acute renal failure, and then you did a urine analysis, and the urine analysis was abnormal. What do we mean that the urine analysis is abnormal? Because we can find some things in the urine analysis which can give us an idea of what is going on in the kidney. If on the analysis of the urine you found out that there are certain casts, especially muddy brown casts, or these are also called the renal epithelial casts. These casts are formed because of the necrosis occurring of the tubules. These are basically the tubules falling off, one part of the tubule falling off into the tubular cavity, and then that is being flushed off in the urine in the form of muddy brown cast. So whenever you find muddy brown cast or renal epithelial cast or the renal tubular cell cast in the urine, then that signifies renal tubular damage, or in this context, acute tubular necrosis. You have some amorphous sediment and just plus minus a few proteins in there, which means that the kidneys are unable to do their job in filtering out the proteins. So this cast picture gives you an idea of that this is some tubular pathology going on. And to confirm that on the urine electrolytes, you find out that the FeNA, or the fractional excretion of sodium, will be greater than 1 or greater than 2. When the fractional excretion of sodium is greater than 1 or 2, that means that the kidneys are unable to absorb the sodium adequately in a normal person. So the tubules are damaged and they are unable to do their job, which is the absorption of sodium. Similarly, the urine osmolality will be less than 350 milliosmoles per liter. Pardon this arrow. This should be the less by 350 milliosmoles per liter. So this means that the kidneys are unable to concentrate the urine as well. So this is a contrasting picture in the both pathologies. In a person with a normal urine analysis or the prerenal azotemia, the FeNA will be normal, that is less than 1. Whether in some, on the other hand, in someone with acute tubular necrosis, the FeNA will be increased, greater than 1 or 2, and the urine osmolarity will be less than 350 milliosmoles per liter. So this patient is classified or identified as a case of acute tubular necrosis. And then we have to see what is going on, what is causing this acute tubular necrosis, whether this is ischemic or whether this is nephrotoxic, because as a result of some drugs which we have given to the patient, or the patient might be taking over a period of time. Now, let's look at some other conditions that can cause renal failure in the context of the renal causes of azotemia. If you find out on the urine analysis that there are WBC casts, or white blood cell or casts, or the eosinophils, or there are certain bacteria, if there are only bacteria and there are no casts, then this can be identified as a case of pyelonephritis, or infection of the kidney. If there are white blood cells casts and along with that there is some bacteria in the urine, this is pyelonephritis. If the casts are eosinophilic, or you find out eosinophils, then there is some interstitial nephritis going on. Interstitium of the kidney is having some inflammation, and this can roughly be defined as an allergy in the kidney going on to certain drug, to certain thing. This might be a drug this patient has been taking. For example, the drug might have acted as hapten, like some penicillins or sulfonamide allergy. This can be because of some food intake or any cause of allergy. And the patient will have other signs and symptoms of allergy as well. The patient might have some hives, or he might have some breathlessness, or he might have some rash going on the body because of that allergic process. So eosinophils in the urine, and specifically eosinophilic casts in the urine, signify interstitial nephritis. And if they are white blood cells and white blood cell casts and bacteria, then you can define that as pyelonephritis or inflammation of the kidneys because of bacterial infection. This can be an acute process or chronic process, which you will go through in the relevant lecture in detail. If you find out that there is red blood cells in the urine, then this might be some renal artery or venous occlusion, which is causing ischemia, which is manifesting in the form of RBCs. So in that case, what you will do is you will do an angiogram to find out the obstruction where it is going on in the kidney, and you will try to fix it as soon as possible, because you know that if you are the kidneys don't have any collateral circulation, and if this obstruction or occlusion is going on for a long time, then that can give to a permanent damage to that part of the kidney. And if you find out some RBC casts or the red blood cell casts along with certain proteinuria, then that gives you an idea that this might be some problem with the glomerulus, or there might be some glomerular pathology going on. To definitively diagnose that, you do a renal biopsy, and on the renal biopsy you are going to differentiate that whether this is glomerular nephritis, inflammation of the glomerulus that is letting the proteins go into the urine to a large extent, and there are RBC casts as well, or whether there is some vasculitis. Glomerulonephritis is most common cause of this RBC cast. There can be some rare pathologies like vasculitis, some syndromes, some anti-GBM diseases, anti-glomerular basement membrane diseases, in which there are some antibodies that target the glomerular basement membrane and make the glomerular basement membrane permeable to all these things, which are generally not found in the urine. Or there are certain immune complex vasculitis or immune complex diseases, the type 3 hypersensitivity reactions that can cause all this. So to differentiate them, you do a renal biopsy and then look at it under a microscope to find out the picture, what is going on, and then you can define that patient as a case of whether he has glomerular nephritis or vasculitis or certain other pathology going on. So this is a very good flow chart, and I explained it in a stepwise process how you are going to proceed. You're going to proceed, start off with a renal ultrasound / CT scan and the urinalysis. The ultrasound will help you in ruling out the post and the prerenal cause, and then afterwards when you have and also the acute or the chronic kidney injury. After you have ruled out the chronic process and you have arrived at a diagnosis of acute kidney injury, acute renal failure, then you look at the urinalysis picture to identify whether it is prerenal or it is an acute tubular necrosis going on. And then if there are certain presentations, then you can identify them as accordingly what is the pathology. And just for the sake of completion, if you have done an ultrasound and you find out this hydronephrosis, then you can see that there is some obstruction going on, and then you do your best to release that obstruction so that the urine is able to be adequately drained into the bladder and in the urethra. All right. Now to just finish off this lecture, let's look at a few terms. Oliguria, as I just mentioned, is generally defined as decreased urine output or less than 400 mL per minute. This is the general presentation of acute kidney injury. What can be the general cause of oliguria? It's the same thing which we have been discussing before. Some pathology in the efferent blood flow that can lead to the prerenal azotemia or leading to the oliguria, some pathology in the efferent arteriole that leads to the decreased GFR, and that decreased GFR leads to the decrease in the urine production. Similarly, if there is certain vasoconstriction occurring as a response to the decreased efferent blood flow, for example, angiotensin II production, or if patient is taking NSAIDs for a long time, then that can constrict the renal efferent arteriole, and that can lead to oliguria. If there is some pathology with the glomerular basement membrane or the glomerulus that leads to the decreased permeability, that can lead to the oliguria. And finally, if there is some obstruction with the help, for example, there are some stones or cancer or BPH in male patients, that tubular obstruction can lead to the decrease in the urine production over a period of 24 hours. And that can also lead to an increase in the tubule back leak when the urine collects here and increases the backward pressure. This is a simplified diagram explaining the oliguria. The major terms which I have explained previously, explaining the azotemia, are the ones which you should keep in your mind. Now, if you have a patient who hasn't passed urine for the last 24 hours, then that patient is defined as anuria, absence of urine production in the last 24 hours. And this can become a medical emergency. The kidneys can get damaged permanently in this patient. Let's briefly look at what can be the causes. Similarly, we will divide it into the prerenal, renal, and the post-renal causes. In the prerenal causes, acutely, if there is severe hypovolemia, the blood volume has gone down very quickly over a period of hours or minutes. For example, someone who is bleeding profusely from esophageal varices, someone who has very explosive diarrhea going on, or someone who has been running a marathon and is not adequately hydrated. That severe hypovolemia can lead to an anuria if the patient doesn't drink a lot of fluids, or the patient has not been taking given IV fluids in case of vomiting, for example, profuse vomiting. That can cause absence of urine or anuria. Or if someone has a dissecting aneurysm of aorta and that can involve the renal artery, then that can lead to an acute decrease in the renal blood supply. And the patient presenting with aortic aneurysms or the dissection of the aortic dissection, it is very important to have a look at the renal function, that whether this aneurysm or this dissection is involving the kidneys or not. If the kidneys are involved, then that carries a bad prognosis as well, and you have to act very promptly. Similarly, if there is some thromboembolism of both renal arteries, this can occur in some manipulations. For example, if someone is presenting with myocardial infarction and you do a angiography, and there are crystal deposition in the coronaries, and then you dilate there with the help of a balloon, those cholesterol droplets can dislodge from there, and then they can go on and lodge into the renal arteries as well. And this can lead to acute renal shutdown, or the patient is the blood is unable to go through the urine, and urine is unable to be produced because of lack of the filtration of the blood. So these are some important prerenal causes. In the renal causes of acute renal failure, again, what we discussed are acute tubular necrosis can cause it, glomerular nephritis can cause it, certain vasculitis can cause it, or if there is malignant hypertension going on. These are the major causes. And in the post-renal, again, if there is a bilateral ureteral ligation because of some mass, for example, any malignancy here, bladder carcinoma, that can involve both the ureters, that obstructs both ureter tracts, or if there is some bladder outlet obstruction like BPH or the cervical invasive carcinoma in the female population, that can present as post-renal azotemia, or eventually, if it goes on for a long time, it can present as anuria as well. So this is basically a revision of the whole previous things which we have discussed about, and we have gradually gone on with the severity. We started with acute kidney injury or azotemia with a decreased GFR, and if it is prolonged, it can manifest as oliguria, and if it is not managed adequately, the patient might go into anuria or renal shutdown. There might be a complete lack of urine production over a period of 24 hours. So the urine production, the volume of the urine produced, the urine analysis, what is the picture of the urine analysis, are there any casts, and are there any cells, is there any infection? These are very good indicators or markers of the kidney function. And certain urinary electrolytes like the calculation of FeNA and the urine osmolarity, that give us a very good insight in differentiating various pathologies, whether they're involving the kidneys themselves or whether they are prerenal or post-renal pathologies. So this was all for the first part of the lecture on urinary abnormalities, and thank you for watching sqadia.com. I'll see you in the second part.